thanks. So the discussion really is a huge one, and what I thought I would do is just take you through a couple of slides of where are we now in this period, what has happened during the COVID period, and where do we think we are going after this period. So, one of the things that I pulled out of the report that we all contributed to and were quite excited about was lessons have been learned, boundaries have been challenged through individual, business, technological, and social innovations. And now what should your or our playbook look like going forward? So that was what we are to talk about today. So I think the starting point is to say the pandemic is far from over. In fact, we're only really starting to get into it now, and it is going to still be devastating. We need to be honest with one another that we haven't even in the Western Cape, where we are seeing a massive uptick, it is only really starting now. And how do we shape the risk intelligent future going forward? Well, if we go back to the report and we say about what Charles Dickens said in the Tales of Two Cities, that is pretty much where we are at the moment. We're in the best of times and the worst of times. And I think at the moment we mostly see the worst of times because things are really difficult. Everything is changing about us. Everything is unfamiliar. And we don't know where we are really going after this. But in fact, it's the best of times for many reasons. And perhaps the statement below, which also came out of the report, is what we need to focus on. We need to be more imaginative. We need to be hugely more empathetic than we've ever been. And we need to work with agency and with absolute intent if we are going to change the way things have been in the past. So we didn't, when we were working on that report and when we were looking at, oops, now I've lost my presentation. Can you see it still? No. Okay, so
yes, we can.
When we were writing the report, we were looking at all kinds of other scenarios and other risks, and we were questioning whether the NHI was the risk or whether whether there were other risks. And we were not even contemplating that we were going to have a pandemic of this proportion, not just for South Africa and what we are trying to achieve with the health system, but for the whole world. We didn't imagine anything like this could happen. And we were talking about the Springs of Hope scenario perhaps being something that we could be focusing on, taking individual and collective charge of our future, and nice words, and talking about building this new consensus to drive a resilient society. And then along came something like COVID. In the report, Clem Santa's global flag watching scenario was called forked lightning, and it talks about the world's markets have another crash as in 2008. But we didn't contemplate, and I'm sure he didn't contemplate, a crash of this proportion as a result of some major global pandemic. So my view is that hopefully nothing will ever be the same again. Hopefully those scenarios was what that we could envisage and that we were perhaps contemplating at the time were completely irrelevant in a way. And that what we need to look at is that nothing in society is ever the same again. We in South Africa have to work to a completely different foundation now when we come out of COVID. And we need to learn from this crisis at every level. And when I talk about every level, the global world will never be the same again. The way we trade, the way we interact, the way we travel, just like this, having a big conference with us all talking on the virtually, and trying to learn our way around new technologies will never be the same again. But even at our domestic South African level, things can never be the same again. Every day's challenges at the moment in the health sector around trying to protect people from the spread of the virus, and we see the huge inequities in the way that society is structured, and we realize we're all equally vulnerable because of one another's vulnerability. And then at a personal level, the way we interact, the way we greet, the way we talk to one another and support one another is never going to be the same again. So what have we learned? Well, at an individual level, I think that for me, we've learned that we are all equal in the face of any crisis, really, but specifically in a massive health crisis like this. We have also learned that if I protect me, I protect others. If I'm positive and I'm not isolated, then I'm an exposure to everybody else, and likewise for the other person next to me. I hope that we've learned that if we don't work together, that many of us will starve to death before the virus gets hold of us. And I think that we have learned there's humanity in every one of us. You still get people who try and abuse the system at every turn, but we've seen amazing, amazing levels of humanity during this time. People are helping one another. We also hopefully have recognized that health is a shared privilege, which was the debate that we were trying to put across during the time of introducing the NHI bill, where not everybody agrees that health is a shared privilege. And we've also learned that recklessness in the way we live, in our health styles and life choices, make us far more risky and make it far more risky for us as individuals. We know that 2/3 of everybody that's dying at the moment has got pretty much a self-inflicted disease, with a few exceptions, and that's mostly diabetes and hypertension as a result of lifestyles, and there are a few other lifestyle causes. So we need to do something about the way we live as individuals. As businesses, we recognize very quickly that most businesses are worth nothing without their people. There are very few businesses that will survive without the staff and without those who buy their products and services. It's meaningless if we don't see it in that context. We know that most businesses have realized that even the most lowly of the jobs in the organization, if you didn't need the job, you didn't need the job. If you've got the job, you need to value the people in those jobs. We've also recognized there are many other ways to do business, and we know that profit is very relative when you're in a survival mode. As far as technology is concerned, if we've not really recognized it before, we now know that the digital age has arrived. We will never, ever hold meetings in the same way again, even if we do travel to go to places. This morning I heard some minister on the radio talking that they've had 4 international meetings this year already, and they used to have 1 or 2 in a whole year in the past, because it's just possible to do it now. And we also know that data drives everything. We've been trying to manage this epidemic and trying to get control of the data since day one. And if you control the data, you're in charge. And that's been part of the battle of trying to react in the correct way to the way we have contained the virus. If we don't know where it's moving, if we don't know who's positive, if we don't know who contacts are, if we can't manage the way in which those contacts are behaving and moving, we can't contain the virus. But at every other level, we know that technology is data-driven, and if you can't manage that data, move into the artificial intelligence space, you will be behind everyone else, because everyone has the same solutions. When I started working on this COVID, we were getting 4 or 5 offers of IT solutions every day, and it went on for the first few weeks. Every day there were people just bringing us new solutions. But every solution is exactly the same. It offers the same stuff. And so the purchasers are now spoiled for choice, and we are going to have to be very discriminate when we select what technology solutions we're going to use. At a social level, social responsibility has been highlighted in so many new ways I can hardly even define them. And social structure will never be the same again. Hopefully, we will learn some things about mental health, alcohol, and some of our other vices during this time. So I said at the time of the report that the risk to South Africa is not whether the national health insurance will work or not. The real risk is doing nothing to both a crumbling, under-resourced, underperforming public health service and an over-serviced, complex, and increasingly expensive private health system that was in 2017 accessible to only 8.87 million people. It's even worse than that now during the COVID time. The risk is certainly as bad as it ever was before. So in that report, we looked at top challenges and top treatments, and how have we done with these? Well, as far as the top challenges are concerned, we talked about the need for significant capital building. And the question is, and the top treatment was to call on big ministers to set up a cost affordable fund. So what has happened? Well, just in the months prior to the COVID and during COVID, significant progress was made in setting up the Health Infrastructure Fund, and cooperation and support of a range of role players was pretty impressive. And there's been extensive unplanned expenditure for COVID, which at least 2/3 of that is going to remain in the system. So we have not even lost the tempo of repairing the health infrastructure as a result of the COVID epidemic. We recognize personnel problems. It's a big challenge throughout the system, but particularly shortage of specialists and general practitioners to service people. And what we've learned is that despite the differences, the private hospitals, the GPs and the specialists have come together. It's been a bit of a bumpy ride getting to where we are because of differences in the way that the systems operate. But there's been a very significant cooperation now and a move towards a common goal. The levels of distrust and resistance in the sector still remains to a certain extent, and there's lots of work to do. And I do believe that now during COVID, because we're forced to work together, we are going to have an opportunity to start to break some of that distrust. Increasing potential of underservicing to save costs within a budget. We've not seen it happening during COVID-19, but our resources have been seriously over-exceeded, and we are going to have lots of challenges when we come out of here. The inability to eradicate corruption, well, I would say that corruption is still with us. We're seeing it during COVID, and we're seeing all kinds of excesses and abuses we're going to continue to deal with. The public awareness and engagement campaigns, we're doing well. And I think we can be fortunate. We've got our current minister who has demonstrated credibility. We could have been in a far worse position had we not had the current leadership in health. Have we managed the treatment to set up proper governance controls and monitoring systems? This is definitely a challenge still, but there has been progress. And of course, as far as the NHI is concerned, we haven't got much further because the bill's still in Parliament and is on hold until we're out of this period. And then the leveraging of technology has been something that we have spent a lot of effort on now during COVID. We've had to convert the entire NHI data management and digital systems to manage COVID. And we have learned so much and implemented so many new systems that the NHI is going to be in a far stronger position by the time we get through this. So all in all, there are more greens than there are oranges and reds in the improvement of the risk that we've seen during the COVID period. So getting to the end of what I wanted to say, the real risk is doing nothing. That's what I said at the time, and I feel the same still now. We cannot, should not, and will not leave the system in the mess that it has been in the past, that it was so expensive and so difficult to manage. COVID has taught us that a single health system is imperative. Those countries that have single health systems have generally done way better than those that have very fragmented systems. We also know that pre-financing in healthcare is an absolute essential, that for inability to have our health prepaid for is a disaster for individuals in a time such as this. We also have learned that if we don't integrate our systems, which is something we knew we needed to do, then it's impossible to manage patient care and to look after the health system. And this has forced us to do it much more rapidly. We do know that leadership, governance, and management are central to success. And although we knew that, we have now seen how and where to make those changes in the system. I believe that had we had an NHI in place, it would have been far easier to manage this epidemic. And we wouldn't have spent so much time trying to break down barriers and work with so many multiple parties. But the bottom line is we have a great deal of work to do. We are nowhere near where we would like to be, and the road is still long ahead of us. Maybe I can take questions, and thank you very much for your time.
Morning, Dr. Crisp. Antonella, so far I'm not seeing any questions coming through. I've got one here from Joe, Dr. Crisp. He says, what does Dr. Crisp, I think he means Crisp, mean by pre-financing of healthcare? What do you mean by that exactly?
Okay, Christopher, thanks very much, and thanks for the question. So the pre-financing of healthcare is where we, through one means or another, pay for our healthcare before we get ill, so that whenever we are ill and need the services, there's always the resources already exist. So for those of us who are familiar with medical aids and have medical aids, this is nothing new, because we pay our premiums, they go into a fund, they're pooled, and hopefully if the risk management is structured correctly, when I'm ill, I'm able to get access to that healthcare. But for the majority of people, there isn't that pre-financing of healthcare. And although governments have budgets, they are so strictly committed to various goods and services that you don't necessarily have all your services covered. So pre-financing of healthcare means that everybody has their money pooled into a fund across the same risk pool, and that you and when you are ill and it's your turn to benefit, your services are already paid for.
Thanks, Dr. Crisp. Just by introduction, I'm the Q&A facilitator. So thank you for Antonella, just to bring me in the discussion. Dr. Crisp, I've got a question here from Anton Schulz. The government does not have a good record of managing state-owned entities. How is NHI going to be any different with the levels of corruption that we face at the moment?
Yeah, okay, that's obviously a good question, and that's the challenge that we have. So first of all, there are state-owned entities and there are state-owned entities, and in fact, of the several hundred, I think there are over 700 public entities in South Africa. There are many of them that are quite well run, but the majority of them are regulators and not businesses. So the ones that are generally poorly run are the businesses, and those are called state-owned enterprises. The rest are called state-owned entities. I don't want to get too much into the technical details, but they are set up for very different reasons, and their structures are run differently. So what this entity is designed to be is not a business. It may not make money. It doesn't invest money. It's like in a way, a bank account, but without the investment side. So although cash that is passing through the entity will be invested in bank accounts, it will mostly be cash rather than investments on the stock exchange and so on. But because it's not trading, it doesn't have the same kinds of risk, the same nature of risk that you would have in a business like Eskom or South African Airways and all those that have bothered us so much. But besides that, the way one sets up any business can either make or break whether you are structured in a way that is going to allow for corruption and fraud. We all know that. So right from the beginning, and I've been involved over a year in setting up what the structure should look like. One of the early things that we did is to design the fraud and risk environment. I wouldn't say to the nth degree, because obviously we need to implement before we do that, but quite strictly. And I co-chair a forum together with Andy Mutibi, who's the head of the SIU, where we are trying to measure the risks, understand where they're going to be, make sure that we design the IT and other systems to make it extremely difficult to defraud and corrupt the system. I can go into some of the examples if you wish, but there's no guarantees. There are never guarantees. There are businesses that we think are doing fine, and then suddenly they get reported in the newspapers that they are involved in corruption or they've lied in their books and so on. So we're not immune to any of that. But the way we set it up is a large part of it. The way we manage the actual risk identification and dealing with them as they arise, and then of course being as transparent as possible. So I'm fiercely defensive of being absolutely transparent, and as to the extent that I'm involved in setting up the NHI, we will from the beginning make sure that everything is in the public domain, visible on the network, on the internet, on the website, and visible in reports, visible to anybody who wants to see what's going on. After all, this is like an account that belongs to us as taxpayers. Thank you.
Excellent. Thank you. Antonella de Cunha, she wants to know, what will the role of medical aids be once the bill is proclaimed?
Okay, so this is one of the things that is most hotly debated at the moment, but the intention of the bill and the wording will still need to be discussed in Parliament, so I don't want to preempt that discussion. But the intention is that we will all be covered for a set of benefits which should be sufficient to cover all the major common illnesses and conditions in the country that we all experience. Now, where that cutoff point is, of course, is a moot point, and that's part of what the challenge is in the first year of setting up a fund like this. And that medical aids will not be allowed to cover that package of benefits, and they will only cover benefits outside of that. So you don't want to double insure. You will be automatically, all of us will be covered and required to contribute, depending on the structures that are finally approved in Parliament, to that set of basic benefits. And then medical schemes will be what are called responsible for top-up benefits. So to try and take one end of the spectrum, for instance, in the private sector at the moment, you've probably read in the media, the people who deal with aesthetic medicine have been devastated by COVID because they're working largely on the face, and they are not essential procedures that they are doing. So those kinds of procedures will not be covered by the National Health Insurance because it's got no demonstrable improvement in the health of the population. But that doesn't mean people will not be allowed to have that kind of care. It's just that they will have to insure themselves separately, and that's the kind of care that medical aids will cover. The jury's still out on exactly what will be where, but that gives you the gist of what the arguments are. Thanks.
Excellent. I just wanted to follow up on a question, Dr. Chris, potentially the last one. Our time will run out at 1:45. Maynard Bester, would the NHI leverage from the learnings and the expertise from the current private health providers to ensure that the NHI is managed appropriate and with the right oversight?
Very nice question. Thank you very much. Okay, so what we need to understand about NHI is that it is a financing mechanism, and it is not the same thing as the entire health system, although of course it will dictate how the health system is structured. So if we try and simplify it into a few building blocks, the NHI strives to achieve a purchaser-provider split, where the purchaser, if you try and think of it how your medical aid works now, you invest money into a medical aid, the medical aid buys your services for you, it determines what you are going to get based on what you've contributed, and then it is responsible for making sure that what it purchases is sound clinical practice, proper governance takes place, you're not being ripped off, it's fair value for money, and so forth. That's pretty much the same thing. And that medical aid will decide, I'm not going to use this hospital, I'm not going to use that hospital, I can do a better deal with this one or the other one. And it does that on the basis of presumably quality and access to its members. It's pretty similar what the NHI will do. So what the NHI bill says is that the fund will purchase from anyone, public or private provider, provided they are accredited with the fund. Now, in order to get accredited with the fund, the first step is to get a compliance certificate. For most private providers, that would be a walk in the park to get a compliance certificate from the Office of Health Standards Compliance. But for some public facilities, that's going to be a serious challenge and require quite a lot of investment, because historically those facilities have not done well. And then they get accredited. And to be accredited, all public and private facilities will need to be accredited. And what that means is that they will say, I would like to deliver X range of the total benefits package. So for instance, one place might say, I only want to do obstetrics and gynae. Another one might say, I only want to be accredited to do cardiovascular. And another one may say, I want to do everything and all general. They get accredited to do that, and they must comply with various accreditation requirements, including the linking to the IT systems and the reporting, and the the sort of normal compliance stuff that any company would need to do. So what will hopefully happen is that those, both public and private, who perform well in their service delivery structure, in the quality of what they deliver, the comprehensiveness of what they deliver, will lead the pack. And there's a bit of I'll pull you up, and the ones at the bottom getting a little bit of a hiding because people don't want to go to them. And the challenge for the NHI is to make sure that those facilities that are, let's call them remote, rural, inaccessible, and provide services to people who don't have purchasing power, that the fund becomes that purchasing power for them and make sure that they do get access. There are ways to do that through investment in management, investment in infrastructure, and twinning and sharing and so on. And we've learned from other countries various strategies to do that. The idea is that we all systematically improve, not that we try and undermine what we've got now that's good in order to hope that maybe perhaps some of the poor services will improve. So make no mistake, this is not something that's going to happen overnight. This is a long journey. It's a bit like COVID, I guess. It's a marathon, it's not a sprint, and you have to systematically make sure that everything that is put in place is a build on to something that you've already got in place at the moment. So, yeah, it's a long discussion, but a great question. Thanks very much.
Excellent. Dr. Crisp, thank you very much. We about out of time on your slot. There are some really cool questions still in the chat box. I don't know about your time. If you are going to be available at the end, we do have a Q&A at the end as well. Alternatively, if you do have time, maybe you'll just find time to respond directly to them. Especially this one question, a very questionable character that's posted this question. His name is Jonathan Crisp. I don't know if he's at all related to you, but it looks like a really tricky question. A tricky question he posted here, so maybe. So, Dr. Crisp, thank you very much. I really appreciate your time and the questions and the time you took to answer them so elaborately. So thank you very much. Please see if you can answer some of these. Otherwise, if we can see you at the back end of this session, great. And we appreciate your time. Thank you very much. Over to you, Antonella.